It is my pleasure to introduce Dr. Constance Dallas.
Thank you. Good morning, and thank you for inviting me, Dr. Florson. This is really, it sounds like there's just so many exciting things going on in Milwaukee. And I'm from Kansas City, Kansas, so, I know that takes me back to exciting, everything's up to date in Kansas City, but I'm really impressed by, it sounds like you're right on the brink of some tremendous excitement, particularly with involving fathers and incorporating fathers here in Milwaukee. So, let me applaud you for leading the way nationwide. Okay, so let me start. Okay, what I'm going to talk about is a summary of recent teen female birth data, some of which has already been covered, the benefits of involving fathers, comparison of health professional and teen father characteristics, some relevant study findings and conclusions and implications, and some questions. Let me say that my background is nursing. I've been a nurse for longer than I'm willing to admit to over a microphone. And the reason that I got interested in this was because I was at a school-based clinic as a nurse practitioner in the Grand Boulevard area. And those of you who are familiar with the Chicago know that, at least during the time that I was there, it had the highest density of poverty in the United States. So I was there in DuSable High School in one of the first school-based clinics, and that's how I became interested in fathers. So of course, as has already been mentioned, there's a lot of state variation, regional variation in the birth rate for teen females, 15 to 19 years of age. And Wisconsin, again, leading the way. Michigan, Iowa, and Illinois rates are significantly lower than the U.S. rate, which is 41.5 per 1,000 females aged 15 to 19 years of age. Of course, in addition to regional variation, there's also significant racial variation, and nationwide, you can see that, of course, there's a big gap between white females and black females and Hispanic females per 1,000. I thought it would be important to look at states around Wisconsin just so that you could get an idea of how you compare. And it looks, again, as if you guys are, whatever you're doing, it seems to be working because it is dropping. But of course, it is dropping nationwide. But maybe you're doing something that other people aren't. Minnesota, of course, is lower. Illinois still has a ways to go. So why would you even bother involving teen fathers? And I'm focusing specifically on teen fathers and even more so African-American teen fathers because that's the population I've worked with the most. So in general, fathers' increased participation in prenatal care, labor, and birth means that you're seeing more of them, that they're coming in contact with you more often, and that you now have to figure out what to do with them. But those of you who are my age, remember that way back in the 1970s, you didn't see fathers because they were stuck in the waiting rooms. And it wasn't until the 1980s that fathers were actually allowed to go into the labor and delivery rooms regardless of whether or not they were married. So this is relatively recent that we're even coming across this contact with fathers. So the partners of teen mothers are frequently a source of maternal support. They influence breastfeeding decisions for those of you who want to really push breastfeeding, and they affect both short-term, there's evidence that they affect both short-term and long-term decisions about well child care. So there's reasons to bring them in. Teen fathers who are involved in their child's prenatal care often remain involved with their children after the birth. And this was a study that used a nationally representative mixed race sample, and they ended up finding somewhat similar outcomes for their teen fathers, for children of the teen fathers and adult fathers, looking at quality of father-child relationships, looking at similar household socioeconomic status, and let me say, again, as Dr. Carson mentioned, that usually there was a grandparent in the household. It isn't that these teens were able to generate enough revenue that they had similar socioeconomic status, but it was usually because of the grandmother. Fewer child support payments, as has already been mentioned, and at least during infancy, the child's cognitive and behavioral scores were similar. But again, as the child got older, the gap got broader. Usually because of lots of low birth weight among the teens, as well as diminished resources. So whether the father is a teen or an adult, children who experience regular positive father involvement, which is what we're aiming toward, tend to demonstrate improved language skills, better academic performance, appropriate school behavior, less risk of juvenile delinquency, and delay the beginning of sexual activity, which again, trying to diminish teen pregnancy is something that we're trying to do. Not a lot of data on teen fathers. Those of you who have looked for it already know that. There's just not a lot out there. Most service agencies do not collect data on fatherhood status or on how many children men have. And they're a difficult group to find overall and to do research with. In addition to that, the birth certificate data for the father's age is often missing, so trying to get really firm data on what the prevalence is somewhat difficult. But what's out there demonstrates, again, like the moms, significant racial differences. I'm focusing on African American males. There is some data there that says that black males aged 15 to 19 became fathers at about twice the rate of white males aged 15 to 19, and that's held pretty steady over the years, that twice rate. They are less likely than either unmarried white or Hispanic teen fathers to live with their children or to marry the mothers of their children. But again, the data that I have didn't follow up quite as long as Marcy's did, but the data that I had demonstrated that they were more likely to remain involved with their kids. And again, these are teen fathers. Health professionals, and when I say health professionals, I'm including all kinds of people who work in the area of work, health, such as social workers, all of you who are doing all that good work that don't necessarily get credit for it, that get sort of, I'm putting all of you under health professionals, so I'm not limiting it to doctors and nurses. But for this, it's important to know that health professionals and the teen fathers, particularly the ones I look at, don't have a lot in common. Very different backgrounds. For health professionals, less than 3% of physicians, less than 4% of psychologists, and less than 5% of dentists are African American ethnicity. So it's highly unlikely when these teen fathers do come in that they're going to see anyone who looks like them. The average registered nurse is a white female who's 46.8 years of age, and now it's even older, and has completed at least an associate degree. And the professional nursing education rarely has content that actually addresses fatherhood models or how to include fathers. So you can see why we might have some problems. When you compare that to African American adolescent fathers, they're twice as likely as the total U.S. population to live in poverty. And because they live in poverty, that quadruples the odds of dropping out of high school. The other thing is there's some evidence that poverty may cause these teenagers to assume adult roles early. Off time, and I'm seeing some nods around the room, okay, and maybe that contributes to the teen pregnancy that they're taking on these adult roles early and off time. Over half live in fatherless home, fewer than half graduate from high school within 4 years, so certainly they're not prepared to be providers, and they often have siblings or parents who became parents during adolescence. Those who do parent often depend very heavily on their own parents for assistance with parenting as well as with material support. Okay, they don't look like us, and they don't really have much contact with us prior to the pregnancy because men tend to utilize fewer health services in comparison with women. They tend to use acute rather than primary health care services. They tend to receive fewer health maintenance visits in comparison with women. And African American and Hispanic teen males, most at risk for fatherhood, often have limited access to health care services. So for some of you, your first contact with adolescent males will be during the prenatal visit or in the labor and delivery room. So now I'm going to talk about the study where my data comes from, which I have to thank my funder, National Institutes of Health, because I want them to give me more money. And I hope they will if I'm nice to them. So my data was very different. It was qualitative, and with qualitative, you look at a smaller sample, but you look more in depth to try to understand more about that subgroup. And the purpose of my study was to look at factors that influence paternal involvement for unmarried, low-income, African-American adolescent fathers from the multiple perspectives of their kinship system. And let me talk about kinship system for just a minute. We interviewed the teen father, whoever was acting as parents for him, whether it was his biological parents or parental surrogates, his pregnant teen partner, and whoever was acting as parents for her, whether it was her biological parents or a parental surrogate. So we called that a kinship system, and the reason we called it a kinship system was because we didn't have a good name. If they were married, we could have referred to their in-laws, but because they're not married, we had to come up with a term because the population that I work with talks about the baby's mama's mama and the baby's mama's daddy, and that just didn't go over with reviewers. So it was much easier for us to come up with a term and call this unit of people a kinship system. Let me just point out that because they talk about their relationship to the baby and not to the couple, then when I talk about grandparents, I'm not talking about the teen father's grandparents. I'm talking about the grandparents to the baby. So the paternal grandparents are the teen father's parents, and the maternal grandparents are the teen mom's parents. Okay, so there were 24 sets of these, and just so that you have some idea of what they look like, they were 14 to 19 years of age, both the teen mom and the teen dad. Not well educated as you would expect at that time. One of the things I would like you to look at, though, is that there were fewer teen fathers in school than there were teen mothers. And I'm not sure exactly what that means, but we had more dropouts among the teen fathers both before and after the birth, and you're nodding, so that's been your experience as well. Okay, our paternal grandmothers, and remember that includes some non-biological paternal grandmothers. Pardon me, the average age was 41 years of age, and they weren't much more highly educated than the teen couples. We didn't see very many with college educations, and of course that's not going to surprise you, given that the average household income was so low. The maternal grandmothers also, about 40 years of age, less than a high school education, and we did find some grandfathers. That was absolutely the most difficult thing to do, was to get the grandfathers for a variety of reasons, some of which were that they didn't have contact with the grandfathers, some of which were they were incarcerated, some of them didn't want to be in a study that looked at fatherhood at all. So we were able to get 11 of them out of the group, and most of them were paternal, and they also, the average was not even high school. Okay, so we collected the data from 2002 to 2007, and I want to point out that we did individual interviews with each member of the kinship system, and we started with during late pregnancy. The girls had to be at least 28 weeks along, and we interviewed each person separately, interviewed them during pregnancy, usually late prenatal, when the baby was 1 month, 3 months, 6 months, 12 months. I used to be able to say this in my sleep. 1 month, 6 months, not 3 months, I'm sorry. 1 month, 6 months, 12 months, 18 and 24 months of age. And at that interview, we wanted to ask specifically, particularly since our funding was National Institute of Nursing Research, what contact they had with healthcare professionals. You know, when did they come in contact with them? Did they do anything to help them? Did they do anything that made it harder for them to act in the fatherhood role? And questions like that. And we have 24-month data on 24 of our 25 kinship systems. So just really quickly, for those of you with qualitative data experience, you take out what is relevant to your question, you code it, you look for repetition across ideas, you then generate higher order themes, hopefully come up with a construct, and then end up with a story that makes sense of all of this. So the perinatal experiences, now these came from interviews with, again, remember the entire kinship system, so these multiple perspectives. Many of the grandmothers weren't aware of whether or not the teen fathers had contact with healthcare professionals, so most of our comments are from the teen parents themselves. What came out of this was we identified 3 major types of interactions that the teen fathers had with these healthcare professionals during the entire study period. The most commonly reported interactions were supportive, and I was really relieved to hear that, which were interactions that supported the teen father by acknowledging, promoting his paternal role. There were 3 types of supportive interactions. They were providing information, providing emotional support, and providing material support. And I'll give you some examples. The people around the adult fathers who promote or inhibit his transition to fatherhood can do that by providing or withholding acknowledgement of his new